Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. A very warm welcome to all of you here attending with us in person and for our extended attendees who are watching us online. On behalf of Bahrain Diabetes Society, it's my great privilege and honor to welcome you to this very informative session designed to talk about preparing our patients for safe fasting during the month of Ramadan. We are privileged today to have with us His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, President of the Supreme Council of Health and President of Bahrain Diabetes Society, and His Excellency Sheikh Mohammed Ramadan, who is here to talk to us about the religious aspect of diabetes as well. So in the beginning, allow me on behalf of myself and Her Excellency Dr. Maryam Al-Hajri to introduce you to this session. My name is Professor Dalal Al-Rumehi. I'm an Associate Professor of Medicine at RCSI and a Consultant Endocrinologist at Awali Hospital. And my role with the Bahrain Diabetes Society is I'm a board member and I chair the scientific committee. During this session, we'll go through a series of presentations starting with Professor Mohammed Hassanein, who will speak to us about new updates in diabetes management during fasting. We will then hear from Dr. Abir Suwair about pre-Ramadan assessment and risk scoring, and then hear from Dr. Rabi Al-Hajri about pre-Ramadan diabetes education and dietary modifications, and from Dr. Sumaya Ad-Dosari on oral antidiabetic medications and the adjustments, and then I'll speak to you about the injectable modifications during Ramadan. At the end, we'll have a panel discussion where we will be joined by Dr. Mohammed Hassanein as well to take questions from the audience online, and end with closing remarks. So we have no disclosures related to this talk, and what is very special about Let's Prepare for Ramadan is this is the second time we conduct this symposium in collaboration and support with Servier. We repeat it every 2 years, understanding there are more evidence and more updates in the scientific literature. So every 2 years at Bahrain Diabetes Society, we are eager to keep our healthcare professionals updated. And it is sponsored, as I mentioned, by Servier. This session is accredited 2 hours of CME professional development points, and you will get them by email once you have registered and logged into the session and completed it. And this event is important because at Bahrain Diabetes Society, since our establishment in 1989, our role is to help spread diabetes education among healthcare professionals. And especially in Ramadan, we understand there are risks and there are challenges to our patients. So keeping them safe during Ramadan fasting is a very crucial role for Bahrain Diabetes Society. And at the same time that we are guiding clinicians, doctors, nurses, dietitians, we are also guiding the patients through our messages, through newspapers, social media outlets, and others, because we believe in patient education as well. All the information you will get today is in accordance with the latest guidelines with the DAR Alliance, Diabetes and Ramadan Alliance. And the presentations, as I mentioned, are conducted by Professor Mohammed Hassanein himself and a group of experts from Bahrain. The addition of a religious figure to our session today adds additional value because we want doctors, nurses, dietitians, etc., to feel the confidence and the empowerment they need when they guide a patient to fast or guide a patient not to fast, because in the Islamic regulations, there are guidance on when we cannot fast, and we will clearly speak about that today. So we thank Surveyor for their support. We have long-standing relationships and collaborations to serve the purposes of Bahrain Diabetes Society with them. And at least over the past 3 years, we've conducted several activities, including May Measurement Month and screened population of Bahrain for hypertension. We did so many activities to educate people on diabetes and hypertension, and then they support us. We thank them for their support on our annual scientific conference as well. Maybe Dr. Maryam, you want to do anything else in the welcoming, or we'll keep it to the closing remarks. So without further ado, I thank you all for attending. I hope you're comfortable at home watching us with a good cup of coffee or a cup of tea and enjoy the knowledge we are sharing today. And we wish you a very successful event. And for those who are not able to join us live or who join us live and then really enjoy the session, you can share this content later on through the YouTube of Bahrain Diabetes Society, because we believe that this knowledge is very valuable to a large portion of healthcare professionals. And now we will start with our blessed opening speech by His Excellency Lieutenant General Dr. Sheikh Mohammed.
بسم الله الرحمن الرحيم والصلاة والسلام على أكرم المرسلين. فضيلة الشيخ محمد رمضان الشيباني، سعادة الدكتور محمد حسنين، السيدات والسادة الحضور الكرام، السلام عليكم ورحمة الله وبركاته. بداية أود أن أرحب بكم جميعا في هذه الندوة الطبية حول مرض السكري وصيام شهر رمضان. وتأتي هذه الندوة في وقت مهم حيث نقترب من شهر رمضان الكريم. وكما نعلم جميعا يعتبر الصيام خلال رمضان التحدي الذي يواجه العديد من مرضى السكري. لذلك فإن تهيئة المرضى بالطرق السليمة قبل رمضان يعد أمرا بالغ الأهمية. أن تهيئة المرضى بالطرق السليمة تشمل عدة جوانب، بدءا من تحسين نظام التغذية وتنظيم جرعات الأدوية والأنسولين ومراقبة مستوى السكر في الدم بانتظام، وضرورة استشارة الأطباء المختصين لضمان أن التعديلات المطلوبة تتم وفقا لحالة كل شخص. وأن فهم التحديات التي تواجه مرضى السكري خلال شهر رمضان وتحديد الاحتياجات الخاصة بهم هو أمر بالغ الأهمية في تقديم الرعاية الصحية الملائمة. من هذا المنطلق حرصت جمعية السكري البحرينية على تنظيم هذه الندوة العلمية الهامة سنويا قبل حلول شهر رمضان المبارك لتعزيز ورفع كفاءة العاملين بالرعاية الصحية لتقديم أفضل الممارسات من تثقيف ومتابعة المرضى وبانتظام من أجل صيام آمن. وأنه من دواعي سروري وأن أرى العديد من الاستشاريين الخبراء والمختصين في مجال الصحة والسكري مشاركين معنا اليوم، فلهم منا كل الشكر والتقدير. كما أود أن أعرب عن شكري لفضيلة الشيخ محمد رمضان الشيباني لحضوره ومشاركته معنا في هذه الندوة حول الحكم الشرعي للصيام لدى مرضى السكري. كما يسرني أن أتقدم بالشكر وخالص التقدير للدكتور محمد حسنين الذي أسهم إسهاما جليلا في نشر الوعي حول أهمية العناية بالسكري أثناء الصيام، وهو أحد خبراء الاتحاد الدولي للسكري في هذا المجال، وله العديد من المؤلفات المميزة في هذا الاختصاص. والشكر موصول للجنة العلمية المنظمة برئاسة دكتور جلال الرميحي ومتابعة دكتور مريم الهاجمي، ولكل من شارك عن بعد ومن حضر معنا في هذه الندوة الهامة. والشكر الجزيل لشركة سيرفير لدعمها الدائم لجمعية السكري. وأسأل المولى العلي القدير أن يبلغنا رمضان بالصحة والأمن والإيمان. والسلام عليكم ورحمة الله وبركاته. مع تلاميذكم.
نشكر معالي الشيخ على هذه الكلمة القيمة، وندعو للمنصة فضيلة الشيخ محمد رمضان الشيباني، وهو أحد الوعاظ المعروفين في مملكة البحرين، وتم ترشيحه من وزارة العدل والشؤون الإسلامية. له منا كل التحية والتقدير.
بسم الله الرحمن الرحيم. صاحب المعالي الفريق ضبيب الشيخ محمد بن عبد الله آل خليفة، الأخوة والأخوات الكرام، السلام عليكم ورحمة الله وبركاته. بداية أتقدم إلى القائمين على هذه الندوة المباركة بجزيل الشكر والتقدير على الدعوة العزيزة. الحضور الكريم، جاءت الشريعة الإسلامية لتحقيق مصالح العباد وتنظيم حياتهم، وأنزل الله تعالى كتابه العظيم لهداية خلقه وجعله نورا وشفاء. إن هذا القرآن يهدي للتي هي أقوم. وأرسل رسوله محمدا صلى الله عليه وآله وسلم هاديا ومبشرا ورحمة، وما أرسلناك إلا رحمة للعالمين. فشريعة الإسلام شريعة كاملة تامة صالحة لكل زمان ومكان. قال تعالى: اليوم أكملت لكم دينكم وأتممت عليكم نعمتي ورضيت لكم الإسلام دينا. والله أعلم بالإنسان وطبيعته وأسرار تكوينه وما يصلحه وما يفسده، ألا يعلم من خلق وهو اللطيف الخبير. ولذلك كانت أوامره ونواهيه سبحانه وتعالى لحفظ الضروريات الخمس: الدين والنفس والعقل والمال والعرض. فهذه الكليات الخمس والمقاصد العظمى التي جاءت بها الشريعة الإسلامية، فجميع الأحكام تدور حول حماية هذه الأصول وضمان استمرار الحياة المستقرة للإنسان. فالشريعة جاءت بتحصيل المصالح وتكميلها وتعطيل المفاسد وتقليلها، فكل ما أمر الله به فهو لصالح العباد. إن الله كان بكم رحيما. إن شريعة الله فيها المعاني السامية والحكم الخيرة والغايات الحميدة التي أراد الشارع تحقيقها والوصول إليها من خلال النصوص التي وردت والأحكام التي شرعت، والتي تحمل في طياتها التيسير ورفع الحرج عن المكلفين، فمتى ما وجدت المشقة وجد التخفيف. قال سبحانه: وما جعل عليكم في الدين من حرج. وقال تعالى: إن مع العسر يسرا، إن مع العسر يسرا. ومن دقة البيان القرآني إخواني وأخواتي أنه قال: إن مع العسر يسرا، ولم يقل إن بعد العسر يسرا، وهذا يعني تزامن وجود اليسر مع وجود العسر. فأباح للمريض الإفطار في نهار رمضان، وللمسافر القصر والجمع للصلاة، ولأصحاب الأعذار ما يناسب حالهم، رحمة منه سبحانه بعباده. فالله تعالى لم يكلف عباده بما لا يطيقون، لا يكلف الله نفسا إلا وسعها. ولا يخفى أن لعبادة الصوم في الإسلام منزلة رفيعة ودرجة عالية جليلة، حيث قرر القرآن الصوم عبادة فرضت على من قبلنا. قال سبحانه: يا أيها الذين آمنوا كتب عليكم الصيام كما كتب على الذين من قبلكم لعلكم تتقون. ولا شك أن العبادات التي تفرض على كل الأمم يكون لها شأن عظيم ومنافع كثيرة. والآيات التي تقرر الصوم تجلت فيها رحمة الخالق سبحانه، حيث أجملت الحديث عن المريض فرخصت له في الفطر. قال سبحانه وتعالى: فمن كان منكم مريضا أو على سفر فعدة من أيام أخر، وعلى الذين يطيقونه فدية طعام مسكين، فمن تطوع خيرا فهو خير له، وأن تصوموا خير لكم إن كنتم تعلمون. وقد أجمع أهل العلم على أن المرض في الجملة عذر يبيح الفطر، ولكن العلماء اختلفوا في تحديد طبيعة المرض المبيح للفطر. وأرجح الأقوال في هذه المسألة هو قول من قال: كل مرض يزيد بالصوم أو يخشى تأخر الشفاء منه بالصوم فهذان يجبران الفطر في رمضان. والمريض على قسمين: أحدهما من كان مرضه لازما مستمرا لا يرجى زواله فلا يلزمه الصوم، لأنه ليس له حال يرجى فيها أن يقدر عليه، ولكن يطعم عن صيام كل يوم مسكينا. الثاني من كان مرضه طارئا غير ميؤوس من زواله، وله 3 حالات: الحالة الأولى ألا يشق عليه الصوم ولا يضره، فيجب عليه الصوم لأنه لا عذر له. الحالة الثانية أن يشق عليه الصوم ولا يضره، فيكره له الصوم لما فيه من العدول عن رخصة الله تعالى مع الإشفاق على نفسه. أما الحالة الثالثة صوم، فيحرم عليه أن يصوم لما فيه من جلب الضرر على نفسه، وقد قال تعالى: ولا تقتلوا أنفسكم إن الله كان بكم رحيما. وقال سبحانه: ولا تلقوا بأيديكم إلى التهلكة وأحسنوا إن الله يحب المحسنين. وفي حديث أبي سعيد الخدري رضي الله عنه قال: قال النبي صلى الله عليه وسلم: لا ضرر ولا ضرار، أخرجه ابن ماجه والدارقطني. ومن هذا المنبر أقول لإخواني وأخواتي المرضى بشكل عام ومرضى السكر بشكل خاص: إن أطباءكم أحرص وأعلم بصحتكم، وإن إرشاداتهم هي السبيل لشفائكم وتخفيف آلامكم بعد الله سبحانه وتعالى، وأن الصبر على آلام المرض والالتزام بالعلاج والحرمان من بعض الأطعمة يعد من الصبر على الطاعة، إنما يوفى الصابرون أجرهم بغير حساب. فالصبر على المرض فيه تكفير الذنوب ورفع الدرجات، وهو علامة محبة الله سبحانه، لأنه ابتلاء من الله بالعبد. قال النبي صلى الله عليه وسلم: من يرد الله به خيرا يصب منه، رواه البخاري. وعليكم بالرضا بقضاء الله والدعاء بالشفاء والالتزام بتعليمات الأطباء، وإذا مرضت فهو يشفين. وإذا منعكم المرض من أداء بعض العبادات التي كنتم تواظبون عليها كالصوم مثلا، فإنه يكتب لكم ما كنتم تعملونه في صحتكم ما دامت النية قائمة. فقد روى البخاري من حديث أبي موسى الأشعري رضي الله عنه قال: قال النبي صلى الله عليه وآله وسلم: إذا مرض العبد أو سافر كتب له من العمل ما كان يعمله وهو صحيح مقيم. وفي ختام كلمتي هذه أتقدم إلى القائمين على جمعية السكر البحرينية الموقرة بعظيم الامتنان على الجهود الكبيرة، وأقول: أملوا وأبشروا بالثواب الجزيل من الله سبحانه وتعالى والممتد إلى ما بعد الدنيا لما تقومون به من نشر العلم والمعرفة والوعي والتثقيف. فقد أخرج البخاري ومسلم من حديث أبي هريرة رضي الله عنه قال: قال النبي صلى الله عليه وسلم: إذا مات الإنسان انقطع عنه عمله إلا من ثلاث، وذكر منها أو علم ينتفع به، الحديث. فهذه الأعمال يتجدد أجرها ويصل ثوابها للإنسان بعد موته. فالطب إخواني وأخواتي أشرف العلوم وأنفعها، ففيه الخير للإنسان وإنقاذ لحياته وتخفيف لآلامه وإعادة لصحته، وغيرها من المنافع التي لا تعد ولا تحصى. فقد قيل إن العلم علمان: علم الدين وعلم الدنيا. فالعلم الذي للدين هو الفقه، والعلم الذي للدنيا هو الطب. وقد روي ألا تسكن بلدا لا يكون فيه عالم يفتيك عن دينك ولا طبيب ينبئك عن أمر بدنك. وقال الذهبي: لا أعلم بعد الحلال والحرام أنبل من الطب. وقد قال الله سبحانه وتعالى: ومن أحياها فكأنما أحيا الناس جميعا. وفق الله الجميع وبارك في الجهود وسدد على الخير الخطى، والسلام عليكم ورحمة الله وبركاته.
نشكر فضيلة الشيخ على هذه الكلمات الجليلة وعلى إثنائه وإطرائه بالطب والعاملين في القطاع الصحي، وهذه النصائح اللي تفضل بها فضيلة الشيخ هي بالضبط ما نأمل أن يسمعه المتعايشون مع السكري وأهاليهم وحتى الأطباء والعاملين في القطاع الصحي. فاليوم بنسمع من محاضرينا الأسس الطبية المبنية على البحوث والقواعد والدراسات اللي من خلالها الطبيب يحدد، وليس اجتهادا بالرأي ولكن على الأدلة الطبية. فلان آمن له الصيام فليتوكل على الله ويصوم، فلان خطر ولا يجوز له الصيام، وفلان في المنطقة اللي يصوم بحذر. فنشكر فضيلتكم على هذه الكلمة القيمة. والآن عندنا ننتقل إلى الجلسة المسجلة. We have a recorded session by Dr. Mohammed Hassanein. Professor Hassanein is a senior consultant endocrinologist at Dubai Hospital, UAE, and he chairs the Diabetes and Ramadan International Alliance, and he's an honorary senior lecturer at Cardiff. We owe a lot of respect to Professor Hassanein because he taught us all about diabetes in Ramadan. He shifted us from opinion-based to evidence-based, and the knowledge that he gained along with his collaborators and researchers is now being used on a global level for people who fast for non-religious fasting. Like intermittent fasting is now common, and they don't have a lot of research. They're going back to Hassanein's research on this matter, and his work has was recognized by the American Diabetes Association, the IDF, so it's always a privilege to have him, whether in person or online. So I hope you enjoy his talk.
Thank you very much for the kind introduction and the kind invitation. I hope you all are enjoying the conference for today. Obviously, Ramadan is very important. It's coming up in less than 3 weeks. And it's important to know what is new in the latest DAR ADA IDF guidelines. Obviously, the work for Ramadan have started 25 years ago or even longer. The first guidelines were 2005, and that's 21 years ago. And before that, there was some work from the Casablanca recommendations and the EPDR study. Indeed, over the last 4 years since we published the last guidelines, there has been 272 publication on the field of diabetes and Ramadan. I'm delighted that some of this work has got us the Sheikh Hamdan Health Innovation Award along with my very good friend and colleague, Dr. Bashar Effendi, and the very dear Dr. Munir Al-Arouj from Kuwait, as well as Dr. Shehra Sheikh from India. This risk calculator has been pivotal, and indeed it has been now part of the ADA standards of care in the previous version, as well as in the latest version of 2026, as well as in the DAR Academy app. So you would say, if the first one of 2021 was so successful, why do we change it? Why do we update? Well, everything needs update, and we have to take stock from all the studies. We have 14 international studies, as well as one meta-analysis from over 10 countries with 10,000 patients plus that have been included in these validation studies. As you can see, many of them are multi-site or from different countries across the globe, which obviously need to be recognized. And one of them is from Bahrain as well. Certainly, the systematic review did look, and all of them have confirmed the predictive value of the risk categories for hypo and hyperglycemia, and perhaps there is room for further improvement. We have to take stock from all the studies that has been published, and this is really quite important. I've here put them so that whoever of you would like to search for them and read them in full, there is plenty of studies and more. I've just here put some of them that we have been involved in as DAR. Certainly, I have to say that we could have not reached this point without the efforts of all the authors from 5 different continents, and not just for the guidelines, but for plenty of the research that was developed and done before the guidelines were published that helped us certainly to make our life a lot easier for the publication of the guidelines. As I mentioned, these are 59 different authors from 5 different continents, and I'm very grateful for all of them. The process of the guidelines was really quite robust. We went through the consensus multi-stage process of reviewing all the evidence, reviewing all the validation, agreeing on some of the points, debating some others until we came to a conclusion, which was agreed by all the authors, which really emphasized the importance for it for people with diabetes, wherever they're setting. Part of the very important new evidence, and you're asking me what's new, there's been a debate on whether hyperglycemia is protective in fasting and whether people with hyperglycemia have a problem or not. And here in this particular study, we looked into the data from 12,500 persons, and we corrected for all the possible potential confounders, such as age, duration of diabetes, comorbidities, type of treatment, including, of course, insulin use, the frequency of SMBG, and whether they received education or not. And we looked into the categories of HbA1c. And you might say that high HbA1c would be easy to fast. But in reality, as you can see here, people with high HbA1c compared to people with better HbA1c of less than 7.5, they had 8.4 higher odds of any hyperglycemic events. Indeed, they had 10.7 times higher odds of severe hyperglycemia requiring emergency care. Someone might say, well, they are hyperglycemic to start with, so that's not terribly surprising, but they would not have problems with hypoglycemia. Well, the data is saying that they also had higher rates of hypoglycemia. When you look into daytime hypoglycemia, breaking the fast because of hypoglycemia, or attending ER or admission because of hypoglycemia. Indeed, hyperglycemia was not protective. It was even worse than those with better control. Moving to another aspect, type 1 diabetes, many of them fast. What if they have kidney problems? Is that a problem? Well, it certainly is a problem, as a clear hesitation to fast and higher burden of complications. 46% of people with type 1 diabetes and any level of diabetic kidney disease decided not to fast. Perhaps those who fasted have slightly better renal function compared to those who did not fast. We do not have the exact problem, the exact information of the renal function. But when you look into hyperglycemia, 79% of those with type 1 and DKD had hyperglycemia compared to 42%. The frequent hyperglycemia was 43% versus 32%. Hospitalization, 3.6% versus 1.9%. So clearly hyperglycemia and even also hypoglycemia, 65% versus 56%. So completely different level of risk, even though we know that 46% already were filtered by their decision of not fasting. What about the renal function in people with type 2 diabetes? And what about albuminuria? Does it matter? And here we looked into people with CKD versus people without CKD on the decision of fasting. And again, those with CKD, much more of them did not fast with type 2 diabetes compared with those who are without. But once they fast, the difference in duration of fasting is not too different. But certainly, when you look into, here is the subcategories of them. Nephropathy is NP and MA is microalbuminuria. So this is the group of no nephropathy or microalbuminuria, and whether they fasted or not, and whether they fasted the 30 days or not. So clearly those without kidney problem, most of them fast, and 2/3 are able to fast the 30 days. But once you start to have any level of kidney problems, whether it's microalbuminuria or nephropathy or both, you see that the rate of fasting goes lower, and the ability to complete the month was only maximum for 60%. When you look into hypoglycemia and hyperglycemia, and again, here is the color code. The light blue is people with both problem, DKD and low eGFR and albuminuria. The green is those with abnormal eGFR but without albuminuria. Orange is the opposite, those with albuminuria but without DKD, and the dark blue is those with type 2 diabetes but without DKD. And the graph is quite clear. For when it comes to hypoglycemia, the more severe the problem, the more the rates of hypoglycemia. And more or less, hyperglycemia, I'm not too sure why the hyperglycemia was higher in those with albuminuria, but not with other aspects. I'm not really certainly too sure. But severity of the problem is very clear. Look into severe hypoglycemia, which means admission to the hospital or a visit to the ER. Very much a crescendo plateau here, or curve rather, between those without DKD and those with DKD and abnormal ACR as well. Retinopathy, does it matter? And we have debated this, and we have the pleasure of collaborating with colleagues from Cornell University in Qatar, Riaz and George, and who collaborated with us in the analysis. We provided them the data, and we together made the analysis. And severe hypoglycemia is certainly much higher, and breaking the fast because of hypoglycemia is certainly higher, as well as hyperglycemia. So although, as I mentioned in the previous study, the methodology is the same, this data is after correction for all the confounding factors: age, duration, insulin, other complications, SMBG, education. So clearly, retinopathy per se was an added factor for the burden of fasting in those who have it, with the severity of hypoglycemia as well as the hyperglycemia. Moving on the microvascular complications. Does it matter if the person have 1 microvascular complications versus 2 versus 3? And again, this is brand new data which we looked into from the survey of 2020 and 2022 with 12,500 persons with type 2 diabetes, of whom 10,700 persons fasted. And we looked into the frequency of the problem. Neuropathy is the highest, and then retinopathy, followed by nephropathy. People who do not have any vascular complications is about 70%. 1 microvascular complication is 22%. Both or 2 is 6.1%, and 3 is 1.6%. Don't forget that this data is answered from the doctor's file and not after thorough assessment. Perhaps if we are to assess in depth, perhaps certainly we'll have more of these complications. But interestingly, the odds ratio for fasting is higher. So many people with 1 problem or 1 microvascular complication would be able to fast, less if they have 2, and even less if they have the 3 problems together. And the same with hypoglycemia. You can clearly see the breaking the fast as well as the severe hyperglycemia is higher. It's there with even 1, but it increases in burden with the increase of frequency of the microvascular complications. And again, the same with hyperglycemia. So, and this is brand new information that we did not have before, and consequently, this really makes us think that having any microvascular complication significantly affect the decision of fasting as well as the risk of hypoglycemia and hyperglycemia. The cumulative burden of having these problems have an effect on the decision, and certainly would have an impact on the decision of fasting or not. What about macrovascular disease? Again, here we ask people about whether they have it or not. We do not know what type of macrovascular disease, and we do not know the severity of it. But again, the decision of fasting was lower in those with macrovascular disease, and the complications were higher, specifically the hypoglycemia complication, the frequency of hypoglycemia, as well as the decision of breaking the fast because probably of the severity of the problem. Hyperglycemia was not statistically significant. So it's really important that we all try to use the electronic medical records, if we have them, to be able to quantify for the risk of the individual very easily. This is a screenshot from my hospital electronic medical records, where it with ease will be able to scroll through items and get the risk level. If you don't have the electronic medical records available with the risk calculator, then you can use the Dar Academy app. So one very important aspect as new in the update for the guidelines is this algorithm. It's not just good enough to say to me, your risk is high, moderate, or low. We need to work together to make Ramadan as a safer month than what it is. And certainly this applies for those who do not fast. I have no doubt in my mind that many of them will not be able to eat and drink during the fasting hours in public. And equally, they will indulge in the big meals that we all engage in during the month of Ramadan. So we have to look after these people as well. But for those who decide to fast, we have obviously to provide them with education, and I'm sure that this will be well covered in the following sessions, as well as address them on the fiber risk factors and give them a trial fast. A trial fast is like the mock exam, and it really would be quite helpful because it will help us to finally personalize the management plan further again, and this would be really quite important. Part of the assessment is the choice of therapy. And this is the latest study that we've published a few weeks ago on the outcome of during Ramadan from the survey on people on sulfonylurea compared to those who are not on sulfonylurea or insulin, which we call them the low risk group. And this is the largest cohort of sulfonylurea trial in Ramadan. As you can see, it does look like we prescribe gliclazide MR a bit more than glimepiride and a bit more than the standard gliclazide molecule. But the vast majority of people are fasting Ramadan. It does look that there is a trend for those on the gliclazide MR to fast at a higher rate than those on any of the other therapies, including the low risk group. The duration of fasting is slightly higher, and the frequency of breaking the fast was lower. But it's important that we understand that even being on sulfonylurea did not inhibit a third of them, roughly. The least was 21%, and the highest was nearly a third of fasting in Shawwal as well. Now, when we look into hypoglycemia, and here is the duration of hypoglycemia. Having hypoglycemia less than 8 days means that it is less than twice weekly. More than 8 days means that it's more than twice weekly. And the color code here is gliclazide short acting is in purple, light green is gliclazide MR, dark green to bluish is the glimepiride, and the gray is the low risk group without any sulfonylurea or insulin. And it is quite interesting that the frequent hypoglycemia was as low as the low risk group in those with gliclazide MR and higher in the glimepiride group. Indeed, experiencing any hypoglycemia was not statistically significant between gliclazide MR and those with low risk, but higher in the other two molecules. When I look into admission to hospital with because of hypoglycemia or any emergency, I'm delighted to see that regardless of the type of treatment, this was pretty low and not statistically significant between them. So sulfonylurea is not of a serious concern, but obviously hypoglycemia and ability to fast is different among the different subgroups of sulfonylurea. Lastly, it's crucial that post-Ramadan, we try to assess what happened during Ramadan, glycemic control, adverse events, because this will give us ammunition for future fasting feasibility, as well as identifying modifiable risk factors for people with diabetes over the following weeks and months. So, ladies and gentlemen, in summary, there's been a lot of new changes and new innovations in this new guidelines. Certainly, these can help us to address the challenges that faces people with diabetes who are obliged to fast if they are healthy adults. The question is how healthy they are. And of course, with the correct guidance, many of them will be able to fast. Certainly, the latest risk calculator has taken into account the success of the previous calculator, as well as all the new studies which make it a more practical and more pragmatic and hopefully more in tune with what people are doing. Definitely, we need to have pre-Ramadan assessment where it to be an opportunity to provide education as well as modify the risk factors, and then finally come with an individualized management plan. Do not forget the post-Ramadan assessment, because really it's quite informative for the care of people over the following Ramadans, as well as the following weeks and months, to address any modifiable factors. Thank you, and I look forward to future meetings, inshallah. Thank you.
So Dr. Mohammed Hassanin will be with us in the Q&A session. So for the attendees who are with us online, please drop in all your questions in the Q&A box. Next, we have Dr. Abir Al-Sawair. She's consultant family physician and consultant diabetologist, and she's the head of diabetes and NCD clinics at the primary healthcare centers, and she's also an assistant professor of family and community medicine at Arabian Gulf University. She's an excellent collaborator with us at Bahrain Diabetes Society, and we're honored to have you.
Thank you, Dalal. Thank you, Servier, and thank you, Bahrain Bahrain Diabetes Society, for inviting me to be a speaker. I'll be talking about very important topic, how to prepare to Ramadan. Actually, we have people fast during Sha'ban and Rajab, and we need to prepare really early to pre-Ramadan and pre-fasting. So I'll be talking about risk associated with fasting, individualized management, because it's all about putting our patient in the center of our attention, pre-Ramadan risk assessment, risk stratification score. I'll touch upon our study DAR-BH that we have conducted like 3 years back, and it's published, and it is cited in American Diabetes Association 2026. We are proudly saying that. Then some conclusion. So the risk associated with fasting, we all stress on that based on numerous studies. Main risk reported are hypoglycemia, hyperglycemia. Long fasting period usually is one of the risk factors, especially in hot climate and conditions, and can lead to complications such as dehydration and increased viscosity. The incidence of DKA seems to be higher during Ramadan. This is a quick comparison between intermittent fasting and religious fasting. I will not go deep through it because of limitation of time, but the common factors are the same. Hypoglycemia risk assessment should be enforced either religious or intermittent fasting. Treatment adjustment is mandatory. So this is the main risk that is common between religious fasting and intermittent fasting. So risk associated with fasting in people with diabetes. However, for many people diabetes, it is a deeply spiritual experience. People are not willing to give up this really spiritual experience, and they will insist on fasting. So many of our patients end up fasting and the break of the fast, perhaps unaware of the risks they are undertaking. And risk stratification, therefore, ahead is an essential, integral part of all diabetes and non-diabetes, and diabetes pre-Ramadan and pre-Sha'ban even fasting. There are different factors used to classify people with diabetes into risk categories, and physicians must weigh the risk factors differently and work according to international guidance. There is broad variation risk stratification, and we need to individualize risk according to the patient's needs and put the patient always in the center of our attention. So as part of the IDF-DAR practical guidelines, experts from the International Diabetes Federation and the Diabetes Ramadan International Alliance have updated the risk classification for fasting, as Professor Hassanin has said. And a healthcare professional managing high-risk individuals that insist on fasting should quantify and stratify risk for every person on an individual basis. Sorry. A risk calculator with various risk variables that we'll be touching upon is introduced, which is flexible in calculating individual risk, empowers physicians, give them the confidence, give them the evidence from all specialties to help categorize individuals that seek fast. These risks are categorized into three main categories: Ramadan-related factors, diabetes-related factors, and factors concerning the individuals. In Ramadan-related factors, there is length of fasting hours above or less than 16 hours. Season of fasting, is it summer or winter? The weather, geographical location, is it up in the north of the pole or here in the Gulf states? Social changes and past experience, which is weighed a lot on the risk calculator. Diabetes-related factors include type of diabetes. Type 1, as Dr. Hassanin has stressed on, has more hypoglycemia, more break in the fast, duration of diabetes, diabetes complication, either macro or microvascular complication. What is the type of antidiabetic therapy? Previous control, is it within the control range or above or below? Proneness to hypoglycemia, hypoglycemic unawareness, and access to care. Factors concerning the individuals, partly they are innate, cannot be changed, like age, gender, occupation can be changed, but pregnancy or lactation, meal pattern, exercise, nature or timing, motivation, especially in religious fasting, the motivation. So pre-Ramadan assessment, this is a ESC ADA-inspired circle of care that we use it for an ADA. And in this situation, the patient, it's highlighted in Ramadan per se. And as we always do, putting the patient in the center of our care. And as we do with other patients in any stage of the disease, we assess his current lifestyle, physical activity, consider comorbidities, atherosclerotic disease, categorize patient to risk groups, clinical characteristics, issues including depression, anxiety, cultural and socioeconomic conditions. Consider specific factors that impact choice of treatment, like individualized high A1C targets, Ramadan impact on weight and risk of hypoglycemia, side effects profile, and so forth. This circle of decision that has been adapted from the inspired by the ADASD obligates the caregiver to make a shared decision with his patients pre-Ramadan in order to categorize his risk. Same thing has been set by the ADA 2026, where pre-Ramadan classification or categorization of risk has been set. I'll talk about pre-Ramadan because my colleagues will talk about other journey of the patient. All individuals seeking to fast should attend a pre-Ramadan visit 6 to 8 weeks before Ramadan. I usually start 3 months because some people, as I said, like to fast Rajab and Sha'ban. Structured education for all individuals should include risk quantification, role of SBGM or let's say CGM, when to break the fast, when to exercise, fluid and meal planning, how to arrange their fluid, how to set their meal plan, and this will be touched upon by Dr. Rabaa. Medication adjustment, and then to stratify the risk and develop individualized management plan according to their HbA1c goal, glycemic goal, glycemic control, their macrovascular complication, microvascular complications, so forth. So detailed medical history is mandatory. Aspects of diabetes and ability to self-manage, presence of comorbidity, individuals' prior experience, very important, managing diabetes during Ramadan. Did you have a problem in the previous year? Did you need to break your fast? Were you rushed into AR for any problems? Individuals' ability to self-manage of diabetes, other aspects of increasing risk of fasting. Then risk stratification into low, moderate, and high. So this year, the ADA has updated, in collaboration with IDF-DAR, has updated the risk scoring and has increased the categories, the elements that we need to study in order to categorize our patient. And for a given individual, each risk element should be assessed and the score should be totaled. And it's very easy. There is a website that tells you, or maybe an app, tells you how to just fill in the elements, and then you get your score. The results in score will determine the overall risk of your patient and clearly tells you, advises you to fast or not to fast, or maybe consider fasting under certain circumstances. So this is the website, and this is how it looks like. Actually, it is in a bigger screen. They have to cut the screen. And this is the risk categories, the risk calculator. The pregnancy has stays the same, but the statement says pregnancy with any type of diabetes. So any type of diabetes, this is a new thing. Diabetes type 1, type 2 was there before, but LADA was added this time. Presence of hypoglycemia is very, very comprehensive in the new risk calculator. Given hypoglycemia and awareness, the very high risk, at the very high point or the very high way. Severe hypoglycemia during the last 4 weeks, 5. Hypoglycemia more than once a day, 4. 6 to 7 episodes of hypoglycemia a week, 3. 3 to 5 episodes of hypoglycemia a week, 2. And 1 to 2 episodes of hypoglycemia a week, 1. Hypoglycemia less than once per week, 0.5. And no hypoglycemia in the last 4 weeks. And this was the 4 weeks cutoff point has been set in this calculator as well. Diabetes treatment has gained so much details in the new risk calculator, where there is you can choose more than one type of treatment, because the patient can be on oral and or can be on insulin as well. Multiple daily premixed insulin 2, once daily premixed insulin 1.5, open loop insulin pump 1.5, once daily premixed insulin 1.5, automated insulin delivery system 1, standard basal insulin like MPH Glargine 100, 0.5, ultra long acting basal insulin like Glargine 300, Diglodic 0.5, short acting insulin 0.75, glimepiride or glipizide 0.75, modern sulfonylureas glycoside MR 0.5, and more than or equal other 2 glucose lowering medications, including insulin sulfonylurea like SGLT2 inhibitors, metformin, DPP4, and so forth. To continue with, nothing, nutrition modification or monotherapy, excluding insulin sulfonylurea 0. Frailty has gained so much detailed in this score, and as Dr. Sumaya maybe told us in the lecture yesterday, there is no identified frailty scale, but it leaves it open for you, for a healthcare professional to choose any. Impaired cognitive function or frailty 6.5. Advanced frailty takes the same way. Mild or moderate frailty 4. More than 70. Now age comes into play in this category. Takes 1, and no frailty or less in cognitive function or loss in cognitive function 0. We've continued. Physical labor has not changed in this calculator. The new category or the new element, fasting focused education. This is very important and has replaced a previous experience from Ramadan. And yes means you received, this is a good thing. No, you did not receive, this is a bad thing. Fasting hours remains the same. Level of hypoglycemic control remains the same. Self-monitoring remains the same, or added. Any type of CGM was added as a bonus, minus 0.5, which is a good practice. Hyperglycemic emergency, HHS has been introduced, hyperglycemic hyperesmolar status rather than the HUNC. And has if there's DKA or HHS in the last month, there's 3.5, DKA or HHS in the last 2 to 3 months, 2, DKA or HHS in the last 4 to 6 months, 1, no DKA or HHS in the last 6 months, 0. Macrovascular complication is the same as before, but microvascular complication has been detailed a lot. With nephropathy remains the same categories as before, while nephropathy, food complications, and diabetic retinopathy, if there are, as Dr. Hassanein has said, if there are 3 microvascular complications, you have 3 risk category way, 2 microvascular complication, 2, 1, 1, and 0, nothing. So we feed the data in our website, in our app, and we wait for the results. The results show instantly. You enjoy the instant totaling of the risk calculator, either low or high, and then you score 0 to 3, there is low risk, 3.5 to 6 moderate risk, and more than 6 high risk. And that means high risk should not fast. And if they do still insist on fasting, the utmost care and monitoring should be provided pre-Ramadan, during Ramadan, post-Ramadan. Moderate risk, if individuals choose to fast, then they advise not to fast. If individuals choose to fast, then they would need to be cautious and discontinue fasting if any problems arise. Fasting here is not advisable, but it can happen. But patient has to be monitored pre-Ramadan, post-Ramadan, and during Ramadan. Low risk should be advised, should be able to fast, and risk stratification should be conducted annually to review the level of risk advances in Ramadan. Ramadan-focused medical education should be insisted upon, and it's one of the elements studied now. Pre-Ramadan medical assessment, including a robust assessment of hypoglycemia awareness, following a healthy diet, physical activity, lifestyle, frequent SBGM or CGM. It's available now, it's cheap, it can be, it's affordable, and we can use it. Modifications to treatment regimen, and all risk categories to ensure safety. Post-Ramadan follow-up is advised to obtain crucial information about the individual risk. I'll jump from this because I bet this will be covered by my colleagues, and I'll talk about the DAR-BH that I was one of its authors. This DAR-BH has consolidated our risk score calculator, where the patients with high risk, where they break the fast the most. So it consolidated the previous risk calculator. We may need to do another one with the new calculator. In conclusion, the risks of fasting include hypoglycemia, hyperglycemia, DKA, and dehydration with viscosity risk. Physicians must quantify these risks and stratify each individual accordingly. And with the current guidance, many people with diabetes can fast safely during Ramadan, but they must be able to, under the close supervision of healthcare professionals, and made aware of the risk of fasting. I think, and the new IDF DAR risk stratification defines 3 risk categories, more elements to examine, more elements to score, and provides a risk score that includes multiple factors that play an important role in the fasting decision recommended for each. Individuals who fast against the advice provided by their healthcare professionals should follow expert and detailed guidance to avoid the development of serious complications. Thank you very much for your kind listening, and we'll have the panel discussion later. Thank you.
Thank you so much, Dr. Abir, for this very informative talk. And we next move to Dr. Rabi Al-Hajri, who will talk to us about pre-Ramadan education and dietary modification. Dr. Rabi at Bahrain Diabetes Society is a board member and the treasurer. And she's a consultant family physician and diabetologist, medical director of Be Well for Family Medicine and Diabetes. Welcome to the podium.
السلام عليكم ورحمة الله وبركاته. في البداية نبارك مقدما بحلول شهر رمضان الكريم، وربي يعود على الجميع إن شاء الله، على مرضانا ومرضاكم بالصحة وبالسلامة. Today I will talk about preparation for Ramadan. Pre-Ramadan education and dietary modification. Why we have to prepare for Ramadan? It is essential for all professionals, all health care to provide, to support their patients, type 1 or type 2 diabetic, to avoid exposure to hypoglycemia or hyperglycemia, and to avoid exposure to dehydration during fasting of Ramadan. This is a practical guideline for safe and fasting during Ramadan by using the IDF DAR practical guideline 2021. As we know that diabetes, it is a burden disease worldwide. Number of diabetic patients, around 537 million patients live with diabetes. And MENA region have the highest prevalence of diabetes. Many Muslims with diabetes, they choose to fast during Ramadan, despite the potential health risk. So we are here today to support all professional doctors to support their patients to have a safe fast during Ramadan. Why we choose this time? As we know that Ramadan, it is not coming as a sudden, so we have to prepare everyone within the family members. We have to educate them. And as I mentioned, it is important to avoid exposure our patient to complication of diabetes. It is not only type 1 and type 2 diabetic patient, it's also the pre-diabetic patient, because nowadays we have a majority of obese, majority of insulin resistance patient. When we educate them how to control their meal during iftar and meal during السحور, it will help them to achieve a target weight and to avoid gaining weight during Ramadan. As we know, suhoor and iftar, the main goal is to provide some patients, they are skipped their suhoor, which can be critical to them, and this issue can expose them to dehydration and to hypoglycemia. So it is important that you can explain to your patient that suhoor, it is very important to delay suhoor as possible. This is number one. Number two, to make a suhoor with a balanced meal, like a complex carbohydrate, whole grains of carbohydrate, to hydrate, to take some of fibers. It will help even to prevent constipation during Ramadan, during fasting. And iftar, unfortunately, our culture that iftar is full of most of the families, especially in the Middle East, it is full of sweet, full of sugar and sugary drinks, vimto, qamar al-din, all these kinds like baklawa, after iftar, qatayif. So this will help and will enhance, keep a patient to have a highly index of glucose, which lead to a severe hyperglycemia, and it lead to a complication of diabetes during Ramadan. There are three core for goal for meal nutritional plan during Ramadan to prevent, as I mentioned, hypoglycemia, to minimize hyperglycemia, and to address comorbidity. Because unfortunately, there is some patients, they missed their other medications for hypertension, for dyslipidemia during Ramadan, and they will expose them to CVAs, expose them to a stroke. So you should enhance, you should convince your patient to focus and to compliance to his other medication like antihypertensive drug and statin and all other drugs during fasting Ramadan. As Dr. Abir she mentioned, preparation, and also Dr. Muhammad Hassanin, preparation of Ramadan, it should be 6 to 8 weeks before Ramadan. It will allow all professional workers, doctors, to advise about the diet modification and risk assessment. 6 to 8 weeks or a visit before Ramadan, it is a very essential First, to assess your patient, to assess his blood report, to check his renal function, if he is in any stages of renal impairment or renal stage 1 or stage 2 or stage 3. Also, to modify and do some modification for the medication for your patients, especially if a patient in oral hypoglycemia like sulfonylurea or others, you can adjust the dose. Some medication, no need to change it, especially metformin, but patient need to adjust the dose of insulin to avoid hypoglycemia. So the pre-Ramadan visit to you as a clinician, it's very important to assess your patient and to educate him. So the comprehensive preparation for SAFE, it should be a nutrition plan. As I mentioned earlier, that carbohydrate and suhoor should be a complex carbohydrate that can provide a patient with maintain a glycemic index, no hyperglycemia, no hypoglycemia. Also in iftar, it should be a balanced meal to avoid severe hyperglycemia. Medication adjustment, I mentioned. Patient education, it is very important to educate a patient and about warning sign of hypoglycemia, warning sign of hyperglycemia, and when to break his fast during the day of fasting. Weight management, as I mentioned, there is a lot of concern, especially overweight patient, obese patient, they concern about gaining weight during Ramadan, but you can explain to your patient that Ramadan, it is a good opportunity to reduce your weight by controlling your food, by doing also some physical activities 1 to 2 hours after iftar, and to continue monitoring your blood sugar, applying a simple and some tools like sensors. It will give you assess your blood sugar and which meal is increasing and which type of food increasing your blood sugar or decreasing your blood sugar. So 6 key risks that can be minimized through proper nutrition. It is, I think, repetition of what I mentioned, but we can add some electrolyte imbalance, some patient having impairment renal function. So it's important to assess the renal function for your patient, and maybe the patient also exposed to renal failure after exposed to severe hypoglycemia or dehydration or hyperglycemia. The common eating mistake during Ramadan, usually according to the culture, what we see and what we heard from our patients, and usually large iftar meal. They are eating a very large iftar meal, more than 1,500, and they continue in eating from iftar till suhoor with a sugary, fatty meals, processed carbs, and sugar-heavy dessert. Eating too fast expose a patient to a severe hypoglycemia, especially after iftar, when he eat very fast sugary food. Pancreas will produce more of insulin, which expose a patient to hypoglycemia and feeling of fatigue. And eating skipped suhoor, as I mentioned earlier, can expose a patient to hypoglycemic risk. We can, by Ramadan, offer an opportunity, as I mentioned, for weight loss. It will help to reduce 0.5 to 1 kg. You can mention to your patient, this is a time you can lose 4 kg in a month of Ramadan. Recommended daily calories for men, 1,800 calories for men to 2,200. Women, 1,500 to 2,000 kilocalories, and woman hair height is less than 150. Hair recommended for hair 1,500 kilocalorie. This already we mentioned. Principles, how to distribute the meal. And suhoor and iftar, patient should have a snacks in between. Carbohydrate to avoid hypoglycemia and iftar or in iftar it should be 30 to 50%, protein 30%. Choose a low glycemic fiber or carbs, the whole grain as I mentioned earlier, and limit a sugary dessert. This is already repeated. This is Ramadan nutrition plate, balanced meal. Choosing a complex carbohydrate with low glycemic index, it is very important. Here is about the protein. As I mentioned, 20 to 30% of the meal should have protein and fat less than 35%. And you can also explain to your patient the modification of how to exchange the fat, what you are using in cooking. You can use a polyunsaturated fat. You can cook at home rather than taking any junk food or from any restaurant. You don't know what kind of oil they are using. This is Dr. Abir. She mentioned earlier about the DAR, IDF DAR tool. And IDF DAR tool, it helps also to manage and to select a meal plan for your patient according to the countries. They customize it according to the cultures of countries. So safe fasting with diabetes, as we mentioned, pre-Ramadan assessment, individualized nutrition plan, risk awareness, and active monitoring for blood sugar during the day. Thank you so much.
Thank you so much, Dr. Rabaa, for this informative talk. And now we'll move to Dr. Sumaya Al-Dosari. She's a consultant family physician and diabetologist, head of Diabetes and Non-Communicable Disease Clinic at Isa Town Health Center. And she'll talk to us about the adjustments needed in oral antidiabetic medications.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Delal. So my talk will be about the oral antidiabetic agent during fasting. We know that fasting during Ramadan introduces a significant metabolic shift that will affect both the glucose regulation during the fasting and the eating periods. So for the patient with type 2 diabetes, these changes consider as challenges. So our primary concern is to maintain adequate glycemic control and to minimize the risk of hypoglycemia. So we have essential manner to do so by using the self-monitoring blood glucose or using the new technology, the CGM, and by adjusting a dose and time of our medication. So how we can do so that we have to continue the stable medication. So the most effective medication can be continued with appropriate adjustment. However, we have to avoid the sudden medication switches near or during Ramadan because it may lead to destabilize the glycemic control. So our rule is to modify the medication, time, and dosing. We have different classes of the oral hypoglycemic agent which carry different risk of hypoglycemia. As I said, our primary concern is to maintain the glycemic control and to reduce the risk of hypoglycemia. So what risk associated with fasting during Ramadan with diabetes? We have the hypoglycemia, hyperglycemia, diabetic ketoacidosis, and dehydration thrombosis. So let's start with our first group, which is the biconide group, the metformin. As we know that metformin is the most commonly used as first-line treatment in many guidelines, and the risk of hypoglycemia in this group is very rare. So if our patient on one tablet daily dose, so in this group there is no dose modifications, either in immediate release or in the prolonged release. So if the patient taking one tablet, so this tablet would be at the same dose taking at iftar. Two tablets, so one tablet at iftar and the other one at suhoor. If the patient take 3 times daily dosing, so the morning dose will be taking before suhoor, and we have to combine the other dosage and should be take at iftar. And the prolonged release metformin, also there is no dose modification and should be taking at iftar. The acarbose, due to its lower efficacy when compared with metformin and the occurrence of the side effects such as flatulence, the clinical use has been limited and it carry a low risk of hypoglycemia, so there is no dose modification with acarbose. We'll skip this one. So the DTP4 group is one of the most famous also group. Results of a study in patients with type 2 diabetes indicate that both vildagliptin, sitagliptin are associated with a lower rate of hypoglycemia during fasting. So also the DTP4 group, there is no dose adjustment. How about the SU? The SU group that are widely prescribed as second-line therapy following the metformin. So in initiation and management of type 2 diabetes, there is extensive evidence base and decade of clinical experience which support the use of this class because it has low cost and it's effective class. However, the risk of hypoglycemia is different significantly across the medication within the same group due to different receptors interaction, binding affinity, and duration of action. So there is a lot of study about the SU in Ramadan. So one of the study by As-Safir and his group in 2011, which compared different medication, the SU group to the sitagliptin. If you see here, those treated with sitagliptin has a lower risk of event if we compare with SU. But if we sub-analyze the SU group, the gliclazide has the lowest rate of hypoglycemia by 6.6. A follow-up, it's double the percentage, the glimepiride 12.4 and 12.4 and the gliclazide 19.7. Other study by Dr. Hassanin and his group on the gliclazide to compare that to the vildagliptin and also show that the symptomatic event of hypoglycemia, there is no difference between the gliclazide and vildagliptin group. Other study also by Dr. Hassanin and his group on the gliclazide MR. So they found that the proportion of the individual with confirmed hypoglycemia is very low. It is 1.6. Okay, so the total case in all the assessment before and during and after Ramadan also 1.7%. And they also conclude from the study that there is no severe hypoglycemia during Ramadan when they are using the gliclazide MR. Also, there was a body weight reduction by 0.5 kg, and there is reduction of HbA1c from 7.5 before Ramadan to 7.2 after Ramadan. The most recent study is the Dire Ramadan study on the gliclazide MR safety, which is enrolled total population of 1,240 across 3 different major regions. We have the Indian subcontinent region, Middle East, and South East Asia. If you see here, the patient with at least one symptomatic hypoglycemia, 1.8, and 2.1 in the Middle East, 3.1 in the South Asia, and with total risk hypoglycemia 2.2. If the patient presents with at least one confirmed hypoglycemia, either symptomatic or not, 1.6 in the Indian subcontinent region, 0.6 in the Middle East, and 2.7 in the South Asia, with a total of 1.6. Also, in this study, there is no severe hypoglycemia across the 3 regions and the total. How about the improving of the HbA1c? Also, if you see here from the graph, the blue bar before Ramadan and the dark after, if you see here the reduction of the HbA1c from 7.5 to 7.2, approximately 0.3 reduction, and it's clinical significant. How about the weight? Also, if you see here, the reduction of weight from 76.5 to 76.5, almost 0.5 kg reduction in the total population. So in summary of this study, it's the first real-world setting in people with type 2 diabetes who fast the month of Ramadan while treated with glycoside MR and show there is no severe hypoglycemia and very low rate of symptomatic hypoglycemia by 2.2, confirmed hypoglycemia 1.6, reduction of HbA1c 0.3, and a reduction of weight by 0.5 kg. We'll skip this study because Dr. Hassanin mentioned in details. So we found that from the study that we have to use SU, especially the second generation, in safety. So how can we divide or adjust the dose of SU during Ramadan? So if the patient on once daily dosing should be taking an iftar, however, if it's very well controlled, we may reduce the dose. If the patient on 2 daily dosing, so one at iftar, the other at suhoor. And also, if the patient is very well controlled, maybe we reduce the suhoor dose. How about the old generations? Is the glycoside, which is carry a high risk of hypoglycemia. So it's better to shift the patient to the second generations, the SU, which is the glycoside MR or the glimepiride, because show from the previous study they have a lower rate of hypoglycemia. How about the SGL2 inhibitor group? So from the DAR survey 2017 till 2021, so the initiation of the SGL2 should be at least 2 to 4 weeks before Ramadan. However, the updated guideline 2026, we can initiate it up to Ramadan after 15 safety trials. And we have to educate our patient to increase the fluid intake from iftar till suhoor. In this group, there is no dose adjustment, but caution should be made with elderly and people on diuretics. Can we initiate the SGL2 inhibitor in Ramadan? If for the cardiorenal protection, we can initiate with caution, and we have to explain to our patient the potential risk and benefit, and we have to advise them to drink enough water to prevent dehydration. The last group from the oral hypoglycemic agent is the oral GLP receptor agonist. The initiation for this group, which is the only oral semaglutide until now available, the initiation should be 6 to 8 weeks before Ramadan to reach to the effective dose, which is at least 7 mg. And we have to avoid the escalation of the dose 2 to 4 weeks before or during Ramadan, and to keep the patient on the maintenance dose 7 mg or 14 mg. So what's the optimal time? The optimal time is better to take it after at iftar, and we have to educate our patient that they have to drink at least 120 ml of water, wait for 13 minutes before eating, drinking, or taking other medication. So better to, at iftar time, we'll take the oral semaglutide, wait for 30 minutes to do our Maghrib prayer, then take the meal. So now we'll go to our clinical case. We have Fatma. She's 37 years old, physical educational teacher with active lifestyle. She has type 2 diabetes for 3 years. She developed the diabetes after her second pregnancy. Her current HbA1c is 7.7, which is equivalent to 61 millimole. Her BMI is 27.5. She's overweight. Her current medication is metformin with a total dose of 1,500 milligram per day on glimepiride 2 mg once daily, which is added 3 months ago when her HbA1c was 8.1. She attended your clinic 1 week before Ramadan, as usual of many of our patients. She gave history that her weight is increased by 1.5 kg since she's starting on glimepiride. Also, she documented 2 symptomatic hypoglycemia episodes during her busy work day. She also gave history that she has infrequent doing her self-monitoring at home, and she has misconception that the glucose testing during fasting may break her fast. So what the patient characteristic we have? Young age, active job, overweight, documented hypoglycemia, and infrequent SMBG monitoring. So, what advice would you give her to improve her glycemic control? So, let us see the choices. Shall we increase the SU dose? We said that since she was started on glimepiride, her weight is increased and there is documented hypoglycemia. So, this is the not best answer for Fatma. Shall we switch her from SU to GLP-1? We said that the GLP-1 should not be initiated at least 6 to 8 weeks before Ramadan. Shall we switch her from SU to DDB4? When we compare the efficacy between the DDB4 to the SU, the DDB4 have a moderate efficacy in reduction HbA1c if we compare it to the SU. Shall we switch her from the SU to SGL2? It's maybe, but we said that we have to avoid sudden or nearby changes to switch the patient from one medication to other. So, shall we change the SU from the similar group? Yes. Better to choose the medication from the same class with the less risk of hypoglycemia and less weight. As we see from the previous study that we have the second generation like gliclazide MR, which has a less risk of hypoglycemia and less risk of weight. So the best answer for Fatma is to change to SU from the same class. So to summarize, the oral medications, how we can classify them. Medication considered to be safe, the biguanides group, metformin or metformin XR. So in these, there is no dose adjustment and should be taken at the same time at iftar. Or DDB4 in combination with metformin or acarbose or pioglitazone. So this is no dose modification and they considered to be safe. Medication also to be safe to continue but not to start SGL2 inhibitor or SGL2 in combination with metformin. Medication safe to continue but not to start also the oral semaglutide, the only oral GLP that we have. Medication that may need to be adjusted or changed due to risk of hypoglycemia, the SU group. So, in our conclusion, managing oral antidiabetic aging during Ramadan need to do a risk understanding and individualized plan. Most of our type 2 patients can safely fast with the oral hypoglycemic agent under medical supervision to maintain their glycemic control and to avoid the risk of hypoglycemia. And thank you.
Thank you so much for this excellent presentation. And I know we're a little over time, so in my presentation, I'll be mindful to catch up so that we can get good time for the Q&A. So finally, we are now moving to the injectables, both insulin and GLP-1 and GLP-GIP dual agonists, and how we can adjust these medications during Ramadan. And I have no disclosures related to this talk. Now, in terms of insulin therapy for people with type 2 diabetes, we know it's commonly used. Many individuals with diabetes type 2 are on insulin And insulin has several types, long-acting basal insulin, quick-acting insulin. And in some of our patients, they have pre-mixed insulin. So understanding what is the regimen and the degree of control is important so that we can tweak the regimen for safe fasting. And we understand that using insulin does increase the risk of hypoglycemia, especially if multiple daily injections are used. So the narrower the control they have before diabetes in Ramadan is the more relaxed we would be in adjusting their doses during fasting. And for people who are on analogs, and I know some of our attendees who are joining us online are probably on older insulins and using regular insulin, for example, it's good to move to analogs before Ramadan. And the doses when you switch to analogs would be 20 to 30% lower than their regular insulin doses because of the more efficacious absorption. And religiously, when we administer insulin, that does not break the fast. And we teach patients that checking your sugar doesn't break the fast. Taking insulin doesn't break the fast. So some of our patients, especially like type 1 who have hyperglycemia and need a correction, or type 2 who have hyperglycemia and need a correction, they can take that and maintain their fast. There are several research studies that looked at the adjustments or safety of basal insulin. And you see here on the screen studies that looked at basal insulin, glargine specifically. And although it has a high risk of hypoglycemia, patients can effectively fast on glargine, also on glargine U300. And I'll walk you in the coming slides on the adjustments we recommend in such doses. So essentially what these slides show you is all of these regimens have been extensively studied in Ramadan. We have newer types of insulin like insulin degludec and the combination of insulin degludec with insulin aspart as well, heavily available in our region. And it's also important that patients are educated, as mentioned earlier by Dr. Rabia, that they measure their glucose and they adjust their insulin doses according to this glucose. So of course, measure glucose so they know if they can continue the fast or break the fast. But also, as I'll walk you through the coming slides, we give them tables to tell them how to increase or reduce their insulin doses accordingly. The higher the risk for hyper or hypoglycemia, the more number of times we ask them to check. And now, luckily, these sensors that patients are using can help us get alarms and alerts and be connected with their healthcare professionals for a safer fast. And I'm more careful with the premixed insulins. Basal and bolus separately are easier to manage than premixed insulin. So in practical terms, this is what we recommend we do with long or short acting insulin dose adjustments. First, we will start with the long acting insulin, as you see here on the screen. So for patients who are on already once daily only basal insulin, what we do is reduce the dose by somewhere between 15 and 30%. For example, if they are on glargine, say 60 units, we will reduce that by 30% and give them 40 units. The tighter their glucose control before Ramadan, the more the percentage of drop. But for patients who are on twice daily long-acting insulin, because some of our patients who are on NPH or glargine twice a day, we keep the one dose at iftar the same, but the second dose that's close to suhoor, half the amount. And for patients who are on short-acting insulin, that's easier to control because it is very governed to their meals. Usually iftar is the main meal, so they continue the dose the same, but because suhoor is a smaller meal, we give them a dose reduction between 20 and 50%. As mentioned, we ask patients to check their glucose. And for their basal insulin, if their fasting glucose, so their glucose before they break the fast, falls between 5 to 7 or 90 and 126, they are really having good control. So their basal insulin should continue the same. However, if they're experiencing hypoglycemia, so say numbers below 70, we advise them to reduce their basal insulin 4 units. If it's in between, it's perhaps more than 70 but less than 90, it's safe to reduce by 2 units. And vice versa, if they're having hyperglycemia, we increase by 2 or 4 units. This piece of education empowers patients, so in between visits, they can do their dose adjustments safely and effectively on their own. When it comes to the quick-acting insulin, it works on the meal processing. So what we teach them is check your sugar 2 hours after the meal. So if it's iftar or if it's a suhoor, and if you are achieving glucose target, that's wonderful. If not, you would either increase 2 units, 4 units, or reduce 2 units or 4 units. If people are on premixed insulin, we may be, before Ramadan, prescribe this regimen as once a day. And in that case, we will take the same dose at iftar. If we are currently, before Ramadan, giving it to them twice a day, the big dose is given at iftar, so unchanged. And the second dose will be typically half of that, and it's at suhoor. If they are before Ramadan taking it 3 times a day, and we understand in Ramadan they have 2 meals, we will omit the middle dose, keep the big dose with iftar and the smaller dose at suhoor, and follow the same scheme because these are general recommendations and only with adjustment we will adjust. Several times in my clinical practice, I will think I need to reduce the dose, but in fact, after they fast, I see they are having so many high numbers that their insulin dose in Ramadan might be higher than the dose before Ramadan. So there isn't a fixed rule. Everybody is their own individual, and monitoring and communication matters. A lot of our patients now are on insulin pumps. Some of the insulin pumps that we have now are automated, and it would make the life of patients and healthcare professionals much easier because it will adjust itself to the glucose values. But if they are manually adjusted and we want to adjust the settings, what we do is the few hours before iftar, so 3 to 4 hours before iftar, we reduce the basal insulin somewhere between 20 and 40%. And accounting for hyperglycemia after iftar, we increase the basal after iftar by 20% for around 1 or 2 hours. The bolus rate remains the same whether they're fasting or not fasting. Now, injectables other than insulin are all these new GLP-1s that are used to improve diabetes care, cardiometabolic outcomes, and weight. So a lot of our patients are on these injectables. As mentioned earlier, when Dr. Sumaya discussed the oral formulations, these should be started before, adjusted before Ramadan, tweaked to the tolerable doses before Ramadan. Also extensively studied within our region in terms of safety in Ramadan, like exenatide, liraglutide, and even semaglutide are studied, and they provide safety, and we don't modify the doses. So these medications are continued at the same tolerable doses during Ramadan as it is before Ramadan. Tirzepatide is also now commonly used for people with diabetes, and several studies are looking at safety of the use of tirzepatide in Ramadan. And also, we continue the same. We do not start or up-titrate such medications before Ramadan because of the GI side effects. And we start preferably 6 to 8 weeks before Ramadan. And because these are effective medications in improving glucose control and reducing appetite, you might notice hypoglycemia from concomitant use of other medications. So we advise healthcare professionals and patients to reduce other medications like insulin or sulfonylurea if needed. And we counsel good hydration, especially if patients show signs of nausea, vomiting, or dehydration. And it's preferred if they will continue to monitor their glucose and break their fast if necessary according with the DAR framework. So in conclusion, many of our patients with type 2 diabetes are using insulin, and some of them use GLP-1 receptor agonists. All are safe to use in Ramadan if we understand the mechanism of action and the safety. And treatment with insulin or GLP-1 based therapies, including the dual incretin agonist, is not a contraindication to fasting when appropriately managed. And knowledge of the type of insulin and dose adjustment aids in minimizing the risk of hypoglycemia. When we are careful with testing glucose frequently, it helps us achieve safe fasting in Ramadan and safe dose titration. And with the use of these injectables, I think now that we have it widely available and sensors are widely available, the communication with healthcare professionals is key, because that will be a key in the success of our patients. We have several questions now. We will move to the panel discussion before we do the closing. I believe we have received some of the questions in the chat, and I will ask my colleagues also to step in.
Good to see you, Dr. Dalal, and I'm sorry I could not be in person. Too much travel for meetings for Ramadan.
Jazakallah khair, Prof. Hassanin, for all the work that you're doing. And I would pass to you the regards of His Excellency Lieutenant General Dr. Sheikh Mohammed, who's with us now, and Fadilat al-Sheikh, Dr. Maryam. We are all delighted to see you, sir.
Thank you very much. My greetings to Fadilat al-Sheikh and to His Highness and everyone.
So maybe, Prof. Hassanin, I start with the questions from the audience. They were targeted to the DAR calculator, if I may.
Sure.
So there is a question about the complexity of the calculator, comparing it to simpler forms like the one we use for pneumonia and decide on admission, etc. Why such a complicated calculator?
Thank you very much for this very important question. While the calculator takes 14 categories, it actually takes less than 2 minutes to do. I would honestly advise everyone who haven't tried it to try it. The beauty of the innovation that you can sit in clinic. I'm lucky to work with electronic medical records, and it's part of our screening records. So I click on screening, it comes up to me. It takes me actually less than a minute to answer. So the person with diabetes have very detailed issues that can affect the fasting. If you were to take, for example, a level of glycemic control for someone who's sitting in an office like me, it's very different than someone maybe doing an intense physical job, let's say a site engineer going up and down exposed to the heat. So some clinical circumstances, but different environmental circumstances. So you have to take into many accounts. If one of the doctors or one of the attendees would be maybe traveling to a country with longer fasting hours, an extra 3 or 4 hours can make a difference. If someone perhaps have a kidney problem, and we've shown the evidence, the beauty of the updated format is with evidence. There's been one study from Bahrain as well as 14 other studies that looked into validation, and they all simply said low is low, high is high, and moderate is 50-50, which is exactly what we say. Even the religious authorities say, if you're moderate, you can try to fast if you wish, but listen to the advice. If you don't try to fast, you have the religious license. And I'm really thankful for all the investigators who've done a lot of studies for us to modify and upgrade. I said it in my lecture, it's like the mobile phone. I just want everyone to remember the mobile phone of 20 years ago versus the one that it's quite sophisticated now.
So I, of course, agree with you. And I think since at the end of the calculation, we are determining safety and risk, and since we're tagging that with a religious opinion from the medical doctor, the more depth of details, the better. And all of this one by one is something you've gathered with references of evidence and research. So each one of those validated categories, although may seem complicated, is very important because we're making a crucial safety and religious decision.
Exactly. And the patient in front of us is very keen to fast, and we're trying to, as much as possible, come to a comprehensive, individualized precision. This is pure precision medicine and pure AI, artificial intelligence, of taking all of these points to give an answer for this particular person.
And maybe I'll move the next question to Dr. Sumaya. It is strongly recommended that SGLT2 inhibitors are not initiated immediately before or during fasting month, with expert advising that patients should be on stable, established doses at least 2 to 4 weeks prior to Ramadan. Can you elaborate on that and tell us if the same is true for the oral GLP-1s?
So we see that the updated 2026 differ from the SGL2. Before, we can initiate at least 2 to 4 weeks before Ramadan. But the updated 2026, after almost 15 trial, the initiated of SGL2 up to Ramadan. And there is a specific consideration if it's for a high-risk people for cardiorenal protection may initiated at Ramadan. The oral SGL2 also from the evidence It's and from the DAR updated guideline 2026, the oral GLP-1 should be initiated at least 6 to 8 weeks to reach to the effective dose, which is at least 7 mg, and we have to maintain that, and we have done to increase the dose during Ramadan.
Thank you so much. And there's a question also, Prof. Hassanin, about in case of elderly history of TIA, is there a risk for fasting?
Well, we said macrovascular disease, so TIAs or stroke would come under it. So if the person is quite stable, then they would score 2. If the person is unstable, they would score 6.5. What is stable and unstable? I'm not a stroke specialist or a neurologist, and I think in the certain circumstances that the clinician need to play their own clinical judgments.
Of course, especially if uncontrolled with type 2 diabetes and risk of thrombosis increase, perhaps the also recency of this episode compared to fasting.
Yeah.
So maybe a question to Dr. Abir, because I don't see pediatrics, and there's a question about, I know for pediatric age group, there is no mandatory or religious need to fast, but if we want to know more about it, is there a resource that you recommend to guide us?
Thank you for the question. I don't really know a resource about this, but common sense, children are not obligated to fast, should not fast, and if they decide to fast, should undergo the risk calculator as well. Especially they'll be type 1, and probably they'll be on pump or something. It's not safe for them to fast. So, Prof, any advice about this?
If I can make a comment, our colleagues from the pediatrics and adolescents have published guidelines, and the latest guidelines include some of them, such as Dr. Asma Deeb and others. We did one study looking into people who are below 18 and above 18. I'm not talking about children now, talking about maybe teens, 13, whatever. We emotionally feel they should not fast. Clinically, they are fitter than the others because perhaps they don't have the complications. Certainly, from Islam point of view, fasting is for an adult. So a child is not obligated to fast, and this is really quite a community issue that they don't feel bullied in the school or in the family circumstances that you're not fasting. If they wish to fast, then obviously we need to try to quantify for the risk and adjust as per all the advice that Dr. Dalal mentioned about the different insulin doses if they're not on a pump. If they're on a pump, it's a lot easier. But clearly, they need to be supported that they are not obliged to fast.
Thank you, Professor Hassanin. I have one comment. Dr. Sumaya, she mentioned about the oral GLP-1 medication. So usually from experience, we are asking a patient to take this medication 30 minutes before meal with a minimal amount of water intake. But during Ramadan, when we are telling them before iftar 30 minutes and patient have to wait, we notice that patient will miss the family gathering of having iftar together. So from our experience, we advise our patient to stop taking food from 11 o'clock or 12 midnight till suhoor, and 30 minutes before suhoor with an empty stomach to have oral GLP-1, so to avoid miss the gathering within the family with iftar. Okay, thank you.
If I would comment on this, we did one study on oral semaglutide, and we exactly say what the colleague mentioned. There are options. Either if there are people who would take a small amount of water and then pray, then they can maybe do that. But if the family gathering is always we eat and then we pray later, then they shouldn't miss and join the family and do what my colleague just mentioned about taking it at suhoor time, provided that they have a number of hours of empty stomach to qualify for this.
So we have a wonderful group of attendees online and several questions. Maybe we'll take one last question and then stop in the interest of time. For patients with very high fasting blood glucose and HbA1c, is it safe to initiate basal insulin in Ramadan? One of the things we learned from Professor Hassanein is don't take Ramadan as an excuse for inertia. Don't compromise diabetes care just because they're fasting. First of all, is this patient safe to fast, yes or no? If they are safe to fast, you will guide them and maybe with vigilance, with caution, small doses and up titrate. But don't say, because it's Ramadan, I will allow for hyperglycemia, because this is when we run in trouble. So safety first. And maybe Prof. Hassanein, any further comments?
I think your advice is very sound. If I'm deemed to be terribly hyperglycemic and my doctor needs to start me on insulin now, perhaps I just need to consider it as if I have a flu and break my fast for a few days until I get used to the insulin, and then I can compensate for these days. Ladies, throughout their life, they are well acquainted to stopping few days of fasting during the month and then replace these days. So I think if I'm not well, if I'm ill, hyperglycemic, I need to start insulin, it's best to play it safe for a few days until I feel stable. If I'm deemed to be able to refast the rest of the month, fine. If not, compensate later during the year.
And I'll be happy to collaborate with the organizers of the event. The choice, if there is an email to share all these questions, I'll be more than happy to, after the session, reply to all attendees. We value their participation. And maybe out of interest, we can have you still, Prof. Hassanein, with us and take a group photo and you're in the background. Is that okay?
Be delighted if the technology can help with this.
Yeah, we'll do the closing comments and then we'll have you still with
Sure.
us at the end.
Thank you.
So, Dr. Mariam, please, if you can give us some closing remarks.
Dr. Delal, مساكم الله بالخير. In summary, I would like to thank His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, President of the Supreme Council of Health and President of the Board of the Bahrain Diabetes Society. His Excellency emphasized the importance of proper medical and health preparation for people living with diabetes prior to the holy month of Ramadan in order to ensure safe fasting and minimize health risk and complication associated with the condition. His Excellency noted that fasting during Ramadan represents a health challenge for many people with diabetes, which need adequate prior preparation. I would like to thank our speaker, Sheikh Mohammed Ramadan Shaybani, who delivered a presentation on the Islamic ruling regarding fasting for people with diabetes, while Professor Dr. Mohammed Hassanein, thanks Dr. Mohammed, our colleague, a leading expert from the Diabetes and Ramadan Alliance, reviewed recent updated in diabetes management during fasting. I would like to thank Dr. Abir Suwair address the assessment of people with diabetes prior to Ramadan and risk stratification, while Dr. Rabi'a Al-Hajri thanks Dr. Rabi'a highlighted the importance pre-Ramadan health education and appropriate dietary modification. Thank you, Dr. Sami Al-Dosari presented a lecture on adjusting oral anti-diabetic, and I would like to thank our Professor Dr. Delal Rumihi for her excellent talks. Thank you, all of you. And in conclusion, I would like to thank all our audience who attend and who are online, and many thanks for Servier who are sponsoring and always support our activities in Bahrain Diabetes Society. I would like to wish you, all of you, a good health and well-being as the blessed month of Ramadan. ورمضان كريم إن شاء الله. الله يعود علينا وعليكم بالصحة والعافية والأمن والأمان. Thank you very much.
Thank you, Professor Hassanein, and we hope you can join us in person next time, inshallah.
Inshallah. Thank you very much,
so
Dr. Adela.
Thank you to all the attendees, and we hope you find this useful. You will get your 2-hour CME through email. And please, if you enjoyed this, it is going to be available on Bahrain Diabetes Society website or on YouTube. So a blessed Ramadan to all of you. Thank you.